Hello, my name is Dr. Roland Owen. I'm a GP in Highfields near Toowoomba. So you have an elderly patient with problems with incontinence. Where do we go from here? First of all, incontinence is fecal and urinary. People often think just urinary, but don't forget it can be both subjects. We'll start off with urinary continence because that is the main sort of problem you tend to come across. So with this problem, one of the first questions is this an acute issue or is it a chronic issue which has only just been unveiled? Then you've also got to look at what type of incontinence is. Is this a stress incontinence, an urgency incontinence, a mixed incontinence? So this sort of issue should be able to be identified straight away from the history or from the carers telling you what's going on. Don't get too hung up in the specific types of incontinence. Normally the type will be related to the underlying pathology and underlying problems. The most simple thing, always remember UTIs, rule that out first things up. Simple, get a urine, do a dipstick. If you're doing a home visit to an elderly patient, bring a urine pot with you and a dipstick with you. It's a great simple starting tool. Otherwise, you just bring the pot and get it sent off. So that should be your knee-jerk response. Just any problems, urinary incontinence, get a urine dipstick or urinalysis straight away without even thinking about it. Once you've done that, you've got to start going through the differential diagnosis list. This can be quite huge and extensive and really textbook stuff, but I'm trying to give you a more pragmatic day-to-day approach. So where do we go next? The sex of the patient is actually quite important here, whether you're thinking in females more uterine pelvic pathology, male more prostatic bladder type pathology. So it sort of gives you a direction either way, the next sort of port of call. And things like constipation too, both male and female, that is an easy, simple, fixable cause. And again, in the elderly, we're always trying to pick reversible, treatable conditions. Another thing not to forget when you are doing your initial history and examination is looking at the social aspects of the problem. Sometimes incontinence can be functional. Can the patient get to the toilet? Can they get to the toilet in time? Have they got carers helping them to mobilise who aren't around always? That type of aspect. Again, think about the social side of things. You can actually save yourself a lot of bother just by identifying it straight up, when realising it's not a physical problem, it's more of a social problem. Back to the sort of physical side of things, usual history and examination, looking at medications. You've gone through UTI, you've gone through constipation, you've gone through some of the local pelvic issues, but always the back of your mind in elderly patients is, could this be malignant? And that's when you're getting into the realms of further investigations, needing imaging and scans. And in the elderly patients, you've got to weigh up the balance, the pros and the cons of, are you going to diagnose this? Are you going to be able to treat it? Is it worth the stress and the bother and the financial outlayings to yourself for time, but the patient and the family too, to investigate this problem? So get the family involved, the patient at the very least and their spouse, but if they've got carers and other family members around them, get them involved in the decision before you go hunting for anything more sinister, more serious. So coming back to fecal incontinence, which I mentioned earlier, this is quite a difficult sort of subject to manage, and investigation-wise it's a bit easier if there's a physical cause, but there's not a physical cause, it can be quite a distressing subject, much harder. Looking at managing it is quite difficult if there's no underlying issue, and one of the biggest problems in the elderly population is it can be related to dementia when there is no easy treatment and cause. And this is when you're looking at using pads and other sort of aids. And don't forget the Queensland Medical Aid Systems scheme. So don't forget the MASS scheme, the medical aid schemes out there for patients to get incontinence aids and pads. Back to the physical causes, I mean, like diarrhea, no. Back to the physical causes, thinking of constipation and overflow diarrhea are one of the most common causes. Gastroenteritis infections, patients in nursing homes, they can often be outbreaks, but you'll obviously have a clue with the other patients being affected. If it's a single patient, you've got to wonder if it's an infective cause, where it's come from. Other infective causes like diverticulitis can cause, but you'd expect some other symptoms like pain. Working our way down the differential diagnosis list, we're starting to get into the realms of cancer again. And like I mentioned earlier, you've always got to decide if you want to go fishing in an elderly patient for a malignant cause. Depends on all the other issues. So once more, consult, talk to the patient, talk to the family before you start doing more invasive investigations and ones with more serious outcomes. There's lots of other differential diagnoses there. Once you've gone through this initial stage, you're getting lower down the list. You've got to be thinking more about neurological causes. Has there been an acute neurological event, a stroke? Have they got any other underlying neurological conditions like Parkinson's diseases? Even rarer conditions like multiple sclerosis can sometimes present but not so common in the older, it's more in a younger patient group. So when you read these lists from a textbook or off the internet, start off with the most common first and work your way down. And that's what we've kind of done today, and hopefully this has given you a starter, an idea of which way to go and what to do. Thank you.